Just make sure it works.
All right, good evening, everybody. Welcome to the next edition of the QC Core Insights. I'm Luke Beffa. I'm at the Cleveland Clinic and be kind of moderating and hosting tonight's session. Tonight we're going to talk mostly about robotic abdominal reconstruction, robotic hernia approaches, any evidence data, surrounding that. We have two great speakers tonight. One, and first I'll just introduce both at the same time and get going. But first is Madion. He is from Northern Michigan and then did some training in the Medical College of Wisconsin, and then does his MIS fellowship currently at the University of Tennessee in Knoxville, where he has a strong focus in ab wall reconstruction. And then after Matt, we are going to have Kevin Baier, who is the man, the myth, the legend, Kevin Baier, who will present us some clinical scenarios, some case stuff, and go through some questions for everybody to see what everyone would do, particularly with robotics, as that is a hot topic. It's very popular. And we're going to find out how much data or how little data there is out there about this stuff. And anyone who's willing or wanting to participate, please either raise your hand or ask questions in the chat, and we'll get to it as soon as we can. And then I want to save some time at the end for questions from anyone else that may have them or want them. So with that, Matt, why don't you go ahead and take it away?
All right, thanks. Is my screen displaying appropriately?
Yeah, you can.
Okay. So yeah, thanks everyone for having me on tonight. This is a exciting topic, something that I think will be changing as my career starts and goes on. So we talked about robotic hernia approaches. Generally, I don't have any disclosures. I'll start by kind of looking at some papers that have compared robotic approaches to other historical approaches, obviously being open or lap, and some of the things that have been looked at. And this isn't an exhausted list, but pain, length of stay, SSIs and SSOs, the overall cost obviously is an ongoing conversation, recurrence rates. And then the nice thing about some of the data coming out of the QC is these specific hernia characteristics that we can look at that's a little bit more granular and more applicable to certain scenarios. But first we'll start by kind of looking at a paper that came out of the Quality Collaborative. It was looking at the open versus robotic retromuscular ventral hernia repairs in a propensity matched review of a total of 333 patients, a majority of which did end up undergoing a TAR as well in that setting. And the screen here, you can show some of the hernia characteristics. I'd like to highlight with this scenario the fact that a large proportion of these patients had moderately sized hernias between 4 and 10 centimeters. So not all of them were those huge, greater than 10 centimeter with defects. And otherwise, beyond the robotic cases taking more time, the overall intraoperative characteristics were similar and not statistically different between the two. And they looked at a variety of things, but specifically looking at the length of stay. This is data before this. Other studies had also shown a reduced length of stay in the robotic hernia approaches, but in a less controlled setting and not as propensity matched and statistically controlled. So this did show a significantly different reduction in length of stay of roughly 1 day compared with robotic compared to open ventral hernias. The other thing worth noting with this was a topic that we will continue to talk about with many of these settings, but there was a higher seroma rate in the robotic group. So an SSO rate, but this did not require any interventions, and the other SSI rates were all the same and equivocal between the two. And then there was the thing I'd like to highlight with this is really, you can consider the benefit of a reduced length of stay when choosing to do a retromuscular approach, knowing that there's probably a downside right now in terms of intraoperative times with the robotic approach. But I think the thing to take away from this study was that some of these TARs that were done in this setting were done for hernias that were probably a little bit smaller than people would really reach for a TAR as their adjunct to a wider defect. So I guess may or may not have been something that would be necessary for all settings, the robotics. And if you want to make comments now between these papers, we can. Otherwise, I'll just kind of move on through some other aspects.
Just keep moving on for your presentation.
Okay.
We'll get to questions at the end. How about
Yeah.
that?
So now we'll talk about robotic versus laparoscopic setting in a ventral hernia repair. And this was I really like this study. This was a prospective multicenter blinded randomized controlled trial, which is very difficult to do in hernia literature. Historically has not done this well. So this was actually reported in a data set earlier than this paper, but it totaled 124 patients. They were all intraperitoneal onlay mesh plus, meaning fascia was closed both in the setting of laparoscopic repair and the robotic repair. And the laparoscopic repair did use transfascial sutures and permanent tacks. So kind of all the hot topics for reasons for trying to avoid a laparoscopic IPOM would be those things, because supposedly and historically they were reported as having higher rates of pain. This data set did show that the robotic cases took more time and were more expensive, but the patient population I also thought is worth looking at here is the patient were majority obese, so over close to 70% in both groups were BMI greater than 30, and the defects were relatively small size. So kind of the patient population that we normally reach for in terms of using a robotic IPOM, at least I would say anecdotally, you reach for as an obese patient who you don't think laparoscopically is going to really work out that well. Small defect, use the robot, do an IPOM, and be able to close the fascia easily. So I thought it was a really well-designed study, and the patient population was appropriate to compare the two groups. And overall, it didn't really show any significant differences in things like wound complications or recurrence or readmissions or patient-reported scores like pain scores and satisfaction scores. But there was a group of patients in the laparoscopic group that did require reoperation, and this was a statistically significant difference between the two groups. So I think the takeaway from this is, maybe historically speaking, we were seeing less pain, or people had studies that were showing less pain with the robotic group compared to a lap group. In some of those aspects like transfascial sutures and tacks may have been contributing to that, but this well-designed study did not show that difference. However, this reoperation rate in the laparoscopic group is just something to consider. I would still probably personally reach for the robot in an obese patient in that setting. But that's kind of an overview of a relatively well-designed study comparing laparoscopic and robotic. And now I'll kind of move into the discussion of comparing robotic approaches. So this kind of just outlines our different options currently in terms of using the robot. We have the onlay mesh, intraperitoneal onlay, transabdominal preperitoneal, which you can do a retromuscular dissection as well as extend out to a TAR in that, as well as the enhanced view total extraperitoneal, which again, you can do a retromuscular with a TAR as necessary in that setting too. This is a recently published study, multicenter randomized clinical trial examining robotic eTEP versus IPOM. The primary outcome was looking at the pain on postoperative day 1, because reportedly, and other groups had reported that the eTEP had less pain compared to the IPOM patients. The defects were relatively, I'd say, moderately sized. They're all less than 7 centimeters. And this a total of 100 patients were looked at here. I think operative characteristics, kind of the recurring theme with more complex dissections in this setting. Once again, the robotic eTEP group did have a longer operative time, but they were able to place a wider mesh in these settings, which is something to consider, I think, when we're discussing certain patients in that possibly need to get mesh laid out further wide. The other postoperative clinical and patient-reported outcomes were relatively the same between the two. The primary outcome was the same. Postoperative pain at day 1 was the same between the two groups. there was a higher rate of seromas in the robotic eTEP group compared to the IPOM, which makes sense, like just based on the tissue planes you're dissecting in that setting. There were reoperations in both groups. There were not statistically significant differences between in terms of reoperations, but the eTEP patient did require mesh excision and bowel resection for their complication, whereas the readmission for the IPOM groups were just for pain. So sorry, clarifying that. No difference between readmissions or reoperations statistically, but the readmissions were clarified there, with the readmission for the eTEP group being the mesh excision. I highlight that just because I think personally, from a technical standpoint right now, being able to see the intra-abdominal contents in a hernia repair when you're robotically, it's a little bit safer from my standpoint. When you're completely kind of extra peritoneal, that visualization isn't as easy. So the risks of something more serious like a bowel injury or something like that is, I would say, a little more possible. This study also did look at things like self-reported workload index using the NASA task load index, which has been used in other randomized clinical trials examining hernias, robotic hernias in particular. And there was a lower task load index reported, statistically different in the robotic IPOM group, which basically means the surgeons felt like it wasn't as much of a mental workload to them doing the IPOM as it was to do the eTEP. And then overall, the costs equated to each other. I don't have the actual numbers listed here, but the benefit of the decreased cost of the mesh used in the eTEP was balanced with the increased cost of the operative time with the eTEP. So overall, things were equated out there. What can we take away about something like this? Pain scores might not be that different between the two approaches. There looks like there can be a better ability to place a wider mesh out. So if you're worried about coverage, maybe trying to get an eTEP approach in that setting, with the understanding that there's typically higher rates of SSOs in that tissue plane compared to an IPOM. And it might be mentally easier than just doing an eTEP. And then the cost in this setting is offset by the cheaper uncoated mesh. So the benefit there is that you do avoid that coated mesh in the cost of it. And I think that concept in itself of two approaches, one which I would argue is a little bit more technically difficult right now from a person who's earlier in their hernia training, IPOM being the easier one, eTEP being the more complicated one, is this study, which was a single institution review of a 7-year period of all the robotic hernias totaling over 600. And this is a super busy table, and it highlights the fact that each of these approaches were also met with a completely different patient population and hernia use and kind of just overall outline of the patient population that was utilized in that approach. The really significant thing, though, to highlight with this is how that changed over time. And this shows that there's a significantly higher rate of adoption of the retromuscular robotic approaches over time, with a reduction in the intraperitoneal approaches. The interesting thing is that the hernia population also changed with that. This institution adopted a more complex hernia practice over time. And this might be a trajectory of people who are actually, taking a career in abdominal wall and hernia repairs, is that this might be the appropriate trajectory from that standpoint, that you can't reach for those super complicated retromuscular dissections right away. So I think that leads us to kind of the final conclusions about this, is that with these robotic approaches, there are particular benefits with each one comparing to historical approaches that have been used or techniques that have been used. And when we're thinking about, comparing between an open or robotic retromuscular repair, you might have a benefit of improved length of stay. When we're thinking about choosing between a robotic IPOM or a lap IPOM, there is the consideration that there has been a higher rate of reoperation, but that's probably not consistent about across all literature. Otherwise, the pain scores have been the same between those two. eTEPs might be something that could be considered when you need wider mesh placement, knowing that there is that higher rate of SSOs if not addressed properly, but things like drains can also address that. But I think long-term, is there a profile of adoption to more complex approaches that needs to be taken? Do we sort of need to be advocating for robotic IPOMs early on in the adoption of the robot, knowing that as time goes on, those more complex approaches could be more utilized as the techniques improve by that particular surgeon? So open the floor for discussion now. I think we'll probably wait until after the cases, but I'll take any questions or clarifications.
I thought that was really good. I'll ask you a quick question, and then while Kevin's maybe getting ready to go, but and then if anyone else has anything, please feel free to chime in. So Matt, you kind of you presented your robotic and lap Mike Wang's paper, and you said something in the middle of it, and you said, I would gravitate more towards robotic IPOM. And I'm just curious as to why you lean that way after reading that paper. I don't know if you meant to say that, or if it was, I'm not criticizing, I'm just curious as to what your thought process was there.
I think I would personally lean more that way for the task load aspect. I know that paper wasn't like looking at that, but that's really why I would lean that way. I think the ease of being able to close fascia and the ease of being able to get the mesh laid out properly and not having to kind of work around corners and stuff like that from a day-to-day standpoint, I think I would prefer that, to be honest. And I personally think that as time goes on with this, as we get our groups more set up from a robotic standpoint, that the time aspect of that is going to come down as time goes on. So that's kind of why I would personally say it's funny, because like we have these settings where people are involved, or like some of our mentors are involved in papers that show these studies, and then they don't change their practices based on it. And that's one for me that like the task load, really, I think it would be better on the robot than it would be for a lap, especially closing fascia. I personally don't have that much experience with closing fascia laparoscopically, because most of the IPOMs that I was doing in my training we're just placing mesh and we're tacking it up, and we're not making any effort to close fascia in those smaller defects.
Yeah, I mean, that's a whole nother a point to make about if you need to close fascia or not for a 4 centimeter, ventral hernia defect, which those, I think, the 3 or 4 centimeters, whatever the average width was with that paper. But I was just curious because, that paper really didn't support much robotic use on the IPOM. And so I was just wondering what your thought process was about how you concluded that way. My other I guess question to you there is regarding a little bit about inguinal hernias. And I know you didn't present any inguinal hernia data, but kind of what are your thoughts on the robot and how it applies to inguinal hernias? And if it's something that you do routinely, you guys do a lot in Knoxville, or you guys tend to do those lap, or what your guys' approach to inguinal hernia stuff is. I don't think we quite had a paper on it, but I wanted to get your thoughts on it.
Yeah, right now I would be choosing, I love a TEP repair and a patient that has a reasonable BMI, but anything that's approaching a higher BMI, I'd be doing a robotic tap. I have not had any training in lap taps, so from a technical standpoint, that's another setting where like mentally, technically I do it, but mentally it's a lot more taxing on me right now. So low BMI patients, non-reoperative areas, I would do a TEP repair, and then a higher BMI patient, I would use a robotic approach.
Could I ask you just a quick question? You kind of brought this up, and I thought it was like fascinating, this stuff. If you go back to that slide in that Coetzee paper, the graph where you show like things are going down. So like, to me, it's interesting how you interpreted the slide, because I interpreted it differently. And it kind of begs the question, which I think is like the kind of the fundamental question about all of robotics, and maybe it's not answerable, which is like, why do surgeons change? Like, what is the impetus to change? And so for most of us, it's because an operation was maybe too challenging, the outcomes aren't good, and you're looking to improve upon something. But it's interesting in this paper, if I remember correctly, all the outcomes are perfect, right? Like the recurrence rate's great, the complication, except for the RTAR, which is the one that's
Yeah.
growing the most.
Yeah. And
Everything is perfect in the IPOM, the RTAP, and the Reeve-Stopa, but they're all dying in his practice. So I'm just curious, like, I mean, just postulate, why do you think he changed?
I mean, it looks to me like he adopted a more complex practice as time went on, and his referral base changed. That's from an outside perspective, that's what it looked like to me, because like it's not like the approaches, like the RTAR patients are not the same patients as the TAP. Like it's a completely different patient population. Yet the over time, basically in 2020, if I'm interpreting things correctly, his patient population is way more complex. But
No, I think actually, if you go back to that thing, I think what he did was he converted from our IPOM to eTEP is what happened. And then he
okay,
added TARs for the more
yeah,
complex ones. But I think he started to do Reeve-Stopas instead of IPOMs. And I've always like wondered, and I think like a lot of people are doing that. Like I get it. I mean, that's the reality of what's happening.
mhm.
But I'm just struck by this fundamental thing of why? Why? And this isn't a robotic argument. It's just more of a why do we change? Like what's driving the forces behind this? And I think it's always worth just like contemplating why you're going to change and think about what are the forces. I don't know the answer. It's just I wonder why that is.
All right, well, food for thought. We will continue on with Kevin Baier, the one and only, and see what Kevin's got for us.
All right, can you see everything? Perfect. All right, so let's see, the first case we have, so it's a 45-year-old female. She started a new job 5 months ago, involves daily lifting. Within a month, she started noticing pain and bulging in her umbilicus. She also has some pain in her right flank without any noticeable bulge, and this has slowly been worsening over the last 2 months, prompting an ER visit and a CT. So her medical history, notable for cervical cancer and obesity with BMI 39, and she underwent a bladder sling and then a robotic radical hysterectomy in 2017. So here is her CAT scan. So just to put us on the defects, umbilical and right flank. So let's talk through how you want to tackle this. So Matt, you were just talking about building your robotic practice. So sometimes I think when you have multiple defects, we can get a little, flustered trying to figure out how we're going to approach it. So I think it helps to kind of think of it one step at a time. So Matt, if you had just the lateral defect, how would you tackle that? I think you're still muted.
The right lateral, you said, yeah. I would probably come. I have to see how high it is, but I would probably come from the left side, come towards it.
All right, and then where would you be thinking about putting your mesh?
Ideally, get out retromuscular out there, so dissect, yeah, retromuscular.
Okay, so you want to drop a like retrorectus dissection and then
Yep.
and tar to get out there.
Yeah.
Okay. And then Aldo, are you on the call? What would you want to do with that lateral defect? Not there.
I don't think Aldo's on, but I'll check.
I thought I saw his name on there.
Oh, Aldo is on. Yeah, Aldo, if you're talking, you're muted, bud.
Or we get like Luciano's take on things,
Luciano or Kayla?
or Kayla.
Well, I want to steer up the discussion. I don't have any experience on doing any of these things robotically, but thinking about approaching both the midline defect and the lateral component, I think I'll probably do it robotically through a left dock approach where I would take the retrorectus, or would do a TAR, extend my dissection laterally, and then I would do a rib stope on the other side. So then I can extend my mesh across the midline and then cover both defects. So it would be a rib stopa on the left side, a TAR on the right side, and the mesh would be retromuscular / preperitoneal, retroperitoneal, and covering both defects. Again, just thinking about the theory, never done it, don't know the specifics about positioning, ports, and others.
Okay. Dr. Beffa, how would you do this?
Yeah, are we talking about just the lateral stuff still, or are you?
Sure. Yeah, we can talk about just the lateral, and then we can expand it to the midline.
Can you run back through the CT scan real quick?
Yeah, of course.
I think it's a little lateral to the
So
semi-linear line.
that lateral defect is basically kind of right above your line of tolt,
Okay.
just lateral to semilinearis,
Yeah.
It's
So
about
you
2
know,
centimeters, and then your umbo is also about 2 centimeters.
first of all, I think if you guys are venturing into the lateral abdominal wall robotically, this is a great first case for that type of stuff, and you definitely want to cherry pick that area of the body. I mean, it's difficult, anatomy is difficult, positioning is difficult to think about, and you want to make sure that you're going to be successful as you're going about stuff. So this is a great one for people who are just starting out for sure. If I was just doing the lateral, the first thing I think about in flanks is I always think about two things. I think about what is going to be the hardest part of the case for me to see. So for flanks, and particularly if you're doing it robotically, I always think the hardest part of this case for me to see is posterior. So, because once you get all that preperitoneal and pretransversalis plane and you're underneath the transverse abdominis muscle and you're dissecting out, if they're supine, getting all that stuff up and off to the psoas at that part of the body is very difficult to see supine. So that would then prompt me to maybe position them more of a lateral decubitus position, like a left lateral decubitus right side up. And that would allow you to access the retroperitoneum more. Now, when you do that, you lose access to the midline. So when you do that with your robotically, you lose some of your access and ability to tackle the midline defect. So to me, I think you have to think about what's going to be difficult and what's going to be easy, and what's, where the hardest parts of those cases are and what you need to get to in order to do an adequate repair. So if it's just the flank, if for this thing, I would do this in a probably not a full lateral decubitus, but probably like a lazy lateral decubitus with maybe a bump, or if you want to use a beanbag, whatever. But I would put that right side up, and I would put my ports through the left rectus muscle. If you go too lateral with your ports, you will be unable to reach all the way medially as much as you want. If you go too medial, you won't be able to get some of that posterior rectus sheath down. And I probably, on the location of that defect, would do retrorectus and then go out laterally to the preperitoneal plane. If they're really posterior, I leave the retrorectus space alone, and I only do like essentially a tap to where you just get into the preperitoneal space and you dissect the whole thing down that way. But for that one, I think you're going to need more medial coverage than just what the preperitoneal space will afford you.
Nice. And then to expand that to the umbo, now you have both defects.
Yeah, if I was gonna do both, I would do this supine. And then like, I'm pretty comfortable with fighting to get back there, but not everyone might be as comfortable doing that. And so I would just caution you that I would never compromise on a surgery or quality of a surgery just to do something robotically. So if there was any doubt in my mind at any point in the case that I was not getting adequate overlap or wasn't getting whatever, then I would convert it to open. But I would do this supine to get the midline.
And so if you were doing it supine, you do retromuscular, both sides, TAR on the right.
Yeah, that's a great question. I was just thinking about that. She's got a little diastasis, and that's a whole nother discussion point. I tend to leave diastasis alone, and I tell them pre-op, I'm like, listen, you're gonna have a little bulging. It's not a hernia, but you got some diastasis, and that's gonna be what you are. My thought that if you were gonna do everything, because that's a pretty small defect, you could potentially put your ports in and do, and I'm only comfortable with doing this because I trained in the era where we did a lot of single dock reef stopa before there was eTEP. And I would put my ports through the lateral abdominal wall on the left side, access the retromuscular space and the ipsilateral rectus muscle, so the left side. On the lateral border of the left rectus muscle, I'd access the posterior rectus sheath. And then I'll essentially do like an eTEP, essentially dissection, where I'd go across the midline, get that hernia down the midline, go all the way across to the right side, TAR the right side, go all the way down, and then close everything on the way out. That's how I would probably approach this if I was going to do it. But that you could also do this as an eTEP and stay totally extraperitoneal if you really felt comfortable that way.
Kind of quick. Oh, go ahead.
I was going to actually call on you, Rosen. I've been seeing you smile over there. So I think like if we back it up and say, okay, what if it was just the umbilical defect? Would people still be doing an eTEP, or would they be doing an IPOM, or what?
I have a question real quick too. Speaking of that, these are both pretty small defects. Like,
Yeah.
I love, like, of course, the robotic TAR, all about it, but why not just primarily close both of these robotically and then do an IPOM for both? They're both pretty small. Especially when those papers, they showed no difference between putting mesh in the retromuscular space, you know? So what do people think about that?
My argument, I'm sure Mike's going to argue with me, but I'll push back a little bit here. I think, so you're talking about, so what would you do? You would do two pieces of different mesh, or you would do one giant 30 by 40 per Yes. What would you, or whatever?
Probably two pieces of mesh sitting next to each other.
Okay.
Like two, like 15 centimeter circular pieces of mesh or something.
I mean, I would say there's probably nothing clearly wrong with that. I don't think there's anything wrong with an IPOM, and clearly, you know, I think that that's certainly an option for this. I don't know. I guess I never really have thought about it that way. I tend to gravitate more towards a single piece of mesh, and I guess that's my bias without any data, whether it's intraperitoneal or extraperitoneal. But yeah, I think that's an option. That's true. But I just don't like that. I don't like that. I don't like putting two different pieces of mesh in two different defects. It just feels weird to me.
Yeah, I guess I don't know. I feel like, you know, as hernias tend to recur, especially if people are heavy, whatever, more of like a step up approach, you know, the way we treat stomas and pancreatitis, you know, like with smaller stuff like this, why not start small before we go big?
Is that Mike Rosen talking, or is that Caleb?
Yeah,
I couldn't quite make out the difference.
You're right. That's incredible. Listen, I just want to echo something for this is such a great case, because to me, this is the bane of hernia surgeons' existence if you have advanced skills. And I think that it's the like small hernias far apart. And that is like this challenge of like, oh my gosh, am I going to take apart this woman's abdominal wall to fix two 1 or 2 centimeter hernias, but they're just far apart. And so I actually think this is a huge dilemma. I personally would just have a really hard time thinking that doing a TAR for these teeny little things makes sense. So like I would struggle with that big time. So to me, I agree with Kayla. Like I'd do a small, I'd probably do 12 by 12 circular. And what I just cut down through the belly button. I'd fix that one that way. And then if you wanted to, I mean, if you really fit, it's probably not what you could even do a tap on the lateral one, or truthfully, I would just do an IPOM over there. She's overweight. She's not going to see or feel any bulging. It's just like, even robotically, it's got to make you feel like taking apart somebody's abdominal wall for these small things. Because you know how it is, Luke, like you start taking down that one side, like where do you end up top? You're going to be like up at her xiphoid. And then because you did it on one side, you got to get close. You can be all the way on the other side. So like, I'm not saying I've never done that, but it definitely gives me anxiety to think, wow, like this is small hernias. Don't you think?
No, I totally agree. I think that's an extremely fair point, and I think that just highlights my bias against intraperitoneal mesh.
Yeah,
To be fair, if I'm being completely honest with you, there's something about putting two different pieces of intraperitoneal mesh in that just doesn't sit right with me. But that is a non-evidence-based decision that I'm putting in there.
I have a bias. That's the problem when two defects are far apart and you're faced with this, like, do I put two pieces of mesh in? It's like goofy. Like that doesn't, I agree with you. That's not like ideal. It's just, that's why this is such a great case.
Yeah,
because it just feels like, I mean, I think everybody who watches this, who's on this call, to say you're going to do a TAR for these teeny little things, you should have some trepidation. That's it. I'm not saying people won't do it. I'm not saying I've never done it, but definitely it should feel uncomfortable because these are pretty small. And that one on the flank, I know Kevin says he's symptomatic, but I don't really believe it. I think she's just symptomatic in the belly button and he's trying to torture us.
Luciano, you have your hand up?
Yeah, Dr. Rosie, if you're gonna do that flank through an IPOM, can you explain to us how you do it and how would you get enough coverage like immediately and all that
Oh yeah. This is exactly what I would do.
Yeah, I saw people trying to do it. Yeah.
Yep. I'll tell you exactly. It's real simple. I would make my cut down at the belly button, and I would put stitches when I cut down. I think Megan showed a video of this last one of these last month. I'd put my stitches to close the umbilical defect when I made my little cut down. So I'd have my port in the umbilicus, and then I would put 3 5s on the left side of the abdomen. And what I would do is bring my mesh through the umbilicus, and I would just tack. No transfascial sutures. I would double crown the hernia on her right side. So that would cover that. Just as a little trick, again, some people have positioning systems. We don't have that. Just don't wet the mesh, and a little 12 by 12 will still kind of have some memory to it. So you can easily just hold it up and double crown tack it. And then I would bring my other 12 in through the umbilicus, or 15 if you needed it, kind of have one stitch coming through, pull it up and double crown, and that's it. That's what I would do. I wouldn't close the defect in the right side. I don't think that matters personally, but I would close the umbilicus on the way out.
Dr. Eunice, I need another robotic guy to back me up in my camp.
I'm not against.
Clearly,
in fact,
Dr. Blake did not train with me enough. So,
well, in fact, but wait. Like I actually think, and I don't have robotic IPOM experience, but I think that could all be equally done elegantly as a robotic IPOM too. Like I don't. Yeah. That's not a.
That's
I don't know about like space and distance. I don't know enough about the robot, but I think you could do an IPOM. Is Jonathan? Are you there? What do you think?
I am here. I didn't think any subjectivity was allowed in this discussion here. Yeah, no, this is something where, I'd be pretty minimalistic. Like, even though I've been enjoying doing a lot of kind of ipsilateral eTEPs and extending them into lateral TARs, I think these defects are too small to warrant that. Absolutely. So I would be likely doing a tap on each one of them. That's, robotic tap. Yes, I would definitely do it robotically. But I wouldn't do, a posterior rectus release. I wouldn't destroy any anatomy other than the peritoneum to fix this.
Is anybody not going to use mesh at the umbilicus? Just curious. No? Everybody? No takers? All right.
TMI 39,
Hey.
and it's incisional. I put her in the study,
Alright.
but I wouldn't.
All right. All right. Just curious. Kevin, what'd you do?
All right. So I took this patient to the OR on Friday, and I did a robotic tap for the right lateral defect, put a 12 by 12. And then I did a robotic IPOM for the middle. And I had a low threshold to finish that IPOM with a tacker on the near side if I had to, because of the issues we were talking about with the port placement. I cheated them as lateral as I thought I could without losing the ability to work over the horizon. I, fought the inability to put them in left lateral by just rotating and giving them a little bump and then having them a little flexed. But yeah, there are definitely those moments where you have these little defects and you have all sorts of tools, but I didn't feel like doing a giant retromuscular and releasing components was the right thing to do for her. And it went pretty well. And she went home the same day. So the other thing to talk about, I think for this, like in terms of that middle defect, Matt brought up that the paper by Kudzi about that experience over time. The one sort of thing I like reading through this paper is the sort of the experience with the TAP approach, and essentially their comments were they had higher hernia recurrence, said lower SSI or like complications, but higher recurrence, and they attributed that to like the limitations of the lateral dissection as the peritoneum gets thin, right? That's that hard spot in between that middle ground and then the lateral rectus, and that's the whole reason we do our retromuscular repairs, to avoid that narrow peritoneum. So especially in a patient like this with that diastasis, when you get in there and insufflate and you get that bowing of the diastasis, and your near side, like if you're going to do a tap, is kind of right on that bow at that junction where the fat kind of peters out and things get really thin. So there was like, to Rosen's dismay, like there was a part of me that was like willing to try it if it looked like obtainable, but it clearly wasn't. So I just brought the stuff down, cephalad and caudal, closed the defect, and did an IPOM.
Nice, Kevin. I think you will forever and always be Switzerland in these questions, and stay neutral. And
well, I congratulate you though, because an R tap, a tap is easier out lateral. So take advantage where it's easier. And to me, it just seems much more difficult in the umbilicus. So then, using your skill set there, I think that's the advantage of the R tap out lateral, is you don't need to put as many fixation points as I would have with my IPOM, and you certainly risk some nerve injury out there. So that's another, like, I think that's a technical advantage of doing that over what I suggested. The IPOM out lateral with all the tacks, you do run a risk of catching some nerves, especially as you start going inferiorly.
And when we get in there, when we got in there, you could see basically there was no peritoneum going in as a hernia sac. You could see scarring. It was right above the line of Tolt. So it really wouldn't have been amenable to an IPOM. You had to at least take the peritoneum down and get the retroperitoneal fat out of the defect. One of the other questions I had was okay, so if you're taking down the retroperitoneal fat, you've gotten to the behind the defect, do you continue in that retroperitoneal plane, like on the muscle, or do you transition kind of back to the peritoneum and leave some of that fat against the lateral ab wall? And then also, like, if you keep going indefinitely on the muscle, what sort of structure can you injure or get some bleeding from? So I don't know if like Megan, maybe, you know, as you come out laterally in your tar and you're on the muscle, and then you look for that cleavage plane and then jump to the peritoneum and leave the RP fat against the ab wall. What happens if you keep going on the ab wall all the way towards like the quadratum?
You'll run into some like bridging veins that come out like from like the vertebrae, like if you come down towards the spine.
Exactly right. So you get those vertebrals, and so you can see at least one of them here coming up off lateral. They swing out behind the psoas and quadratum and then come out into that lateral ab wall. So that's also a consideration if you're in a spot where you're like hugging the muscle out laterally, just for folks to think about.
Great points. Dr. Blake, do you have your hand up?
Yes, I had a question for you, Dr. Beffa. I have a case exactly like this coming up. I just saw him in clinic, but that flank defect is about 10 centimeters and the umbi looks the same as this. And I was planning on doing a robotic tar on this. How far back can you get in that robotic position? Like, can you get all the way to medial border? So like, how far back have you ever gotten on a robotic tar with this type of approach, doing umbi and a flank? How far? So as
not supine, you really, it's almost impossible to get back there robotically supine. You can get onto the psoas, like, you know, like when you're doing like an inguinal hernia, you know, you get down to the psoas in the pelvis, like you can get down there, but in like the middle of the abdomen, it's not. It's just too deep. It's impossible to get that far. So I think when you have a big flank hernia defect, I personally don't know if the robot is the best tool in that scenario. I have tried to tackle them before when they're big, like 10, 15 centimeter flanks robotically. I struggle a lot with medial overlap with them. Because a lot of times when they're that big, they're really close to the rectus muscle. And then if you only have a rectus that's maybe 5 centimeters wide or whatever, are you comfortable enough to just stop at the lineal? And then if you have to reinforce lineal with a midline defect anyways, you know, I would say it would be almost impossible to get back that far. The other thing about flanks with robotics is it's hard to get a heavyweight mesh through an 8mm port. It's not impossible, but man, is it difficult. So you're going to have a 12 or bigger to get a heavyweight mesh in, which we do prefer in lateral defects in the lateral abdominal wall. So I just don't know if big flanks are great robotically, to be fair.
Sounds good.
Your thoughts, but
yeah, I didn't know if you ever tried to like bump them up to get all the way back to that.
I have and failed multiple times. I've called Alfie about it. He's like, "What's wrong with you?" But I just can't. I can't seem to make it work to a point where I'm happy with it.
Got it. I'll book them open. Thank you.
Awesome. All right, so we got 10 minutes left. Do folks have more questions? Do you want to do a second case real quick?
Let's go second case real quick.
All right, 33-year-old. She comes in with 1 month of bulge. She has pain that radiates to her back, and on exam she has a periumbilical ventral, and then she's got what feels like a small primary epigastric just above it. She also has some diastasis. Her BMI is 33. She has a history of a lap tubal. Here's her CT. All right, so some decent diastasis, umbilical defect, and another like a primary epigastric right above it. And let's see, we'll just we'll cut a little to the chase here. So being the scholar that you are, you offer them participation in your IPOM eTEP trial. They randomized to eTEP. You position of supine, you flex the bed, you get in there. A little bit difficult with the crossover, make a couple holes, you're worried about what's on the other side. So you take a look intraperitoneally from the other side. Everything looks okay. You finish your crossover, you close all your holes, you close your defect, you place a 12 by 12 centimeter medium weight mesh, and you feel like a hero. You know, at that time, we didn't have the results from our robotic eTEP versus IPOM trial. We were in it to win it. And so, but it's worth talking about how those have panned out a little bit. And so at the end of the day, the robotic IPOM was a little bit faster by nearly 60 minutes, had fewer SSOs, but that wasn't terribly significant. And then otherwise, pain, length of stay, opioid consumption, 30-day quality of life, all of those were the same. We're waiting, hopefully soon we'll have the 1-year follow-up. So this patient comes back 10 months later and reports a new bulge. You examine her and you concur. Here's her repeat CT. All right. Matt, what do you think went wrong here? And what do you want to do about it?
Doctor muted. Oh, okay. Got it.
It looks like the mesh may have migrated.
Did Kayla teach you how to blame the mesh? Is that what you've learned in the first couple months? She taught you to blame the mesh?
Oh my gosh, get out of
That
here.
stinking mesh. Where did it walk away from?
Can't be the technique. That's perfect.
Yeah.
Regardless of whether or not the mesh is to blame, you've got a
Yeah.
small defect just above the mesh. You still have some diastasis. What do you want to do about it?
I think, I mean, given the results of that study, I mean, not that they were, I think you could probably just go for a IPOM at this point and not try to have to get back into that plane.
Yeah. So just because we only have a couple minutes left, I think an IPOM is a great tool to have after like a prior retrorectus that has like a cephalator-caudal recurrence. My like personal thought on this type of recurrence is probably an injury to the linea as we develop that posterior rectus space and kind of chase up and down. And then we don't have mesh overlapping that. So you are going to do an IPOM, and do you want to do it lap or robotically? We talked about that that paper from Liang's group, and you know, so at the end of the day, no significant differences from their paper. The other randomized controlled trial comparing these two, the PROVE trial, had some slightly different results. I don't know if any of the residents from CCF are on there, but at 1 year follow-up, the composite recurrence was quite different between the two. It was 7%, or sorry, it was 6% in the lap group and 24% in the robotic group. So is a little bit smaller study. The follow-ups in the middle of COVID, only half of those patients had clinical evaluation. So a lot of that is based on PROs, the Ventral Hernia Index. Two papers, a little bit different findings. Obviously, it's just a starting point. You know, you need more people. need to pool resources, need to do a bigger multi-center trial, get your meta-analysis, take all that data together, and that's how you kind of get to the answer. So you decide to just go in laparoscopically, and this is what you see. Small defect right above your mesh, right at the base of the fallacy. So you cut down, you drop your mesh in just like Dr. Rosen told you to, you close the defect, you tack it up in a double crown, and you're all done. Now you're a hero. And I think we're out of time.
Can I ask Matt one quick question? Matt, if it wasn't right to do an IPOM the first time, and for like just saving all these lives, we have to get mesh outside the peritoneal cavity, because otherwise it's the bane of every hernia surgeon's existence somehow. Why is it okay to put an IPOM in after eTEP failure?
I mean, I think the point is that it proves that we could have done an IPOM the first time, I think was probably
Why are we
the point.
even futzing around with eTEP for these small hernias? Why do that? Any ideas? You're a young budding hernia surgeon about to go out and practice. Why are you digging down that hole?
People think it's cool right now.
Okay. All right.
At least
all
you're
right.
honest.
Fair enough. Fair enough. Fair enough. I think that's a fair. Plenty of people do cool things that when you get older, you look back and think,
Yeah.
wow, that was stupid.
But Matt, how many eTEPs have we done, and how many robotic IPOMs have we done?
No, I mean, I'm saying people think it's cool. I'm not saying that I mean, I have not done an eTEP with you yet. So, I mean, we've done plenty of robotic IPOMs. So, I mean, I think that the reasoning behind it is not valid at this point, but people think it's cool and that's why they're trying it.
No, I think that's great. No shame in that. I just think always, like I said before, and I asked you, like, why do we change and why do we do things? And like, I'll make one quick comment. I'll let you guys finish it off. Is that having done a lot of open reef stopas, I would caution one thing: where you end the dissection and end the mesh, open and robotically, whatever, when you've taken in that retromuscular plane, is challenging not to get hernias at the top or bottom of your mesh. And that's an inherent limitation of a reef stopa, by the way. So then you're kind of left with this: do we carpet people from top to bottom when we mess around in those spaces? And I think this is a complication that can happen after open reef stopa too. It's just a weakness of doing a small kind of retromuscular operation.
All right, guys, I think we're out of time. Thank you to Dr. Madion and Dr. Baier for presenting and putting this on tonight. And thanks to Megan for organizing everything. And this is a great discussion. I hope we all had some food to chew on and think about tonight and figure out why the heck we want to get mesh outside the abdominal cavity. So that's your homework. All right, I think that's it. We'll wrap it up here and everyone get back to work.
And one quick announcement, everybody, QI Summit coming up first week in March. It's on our website. Please come. It's going to be great. We have great speakers, great talks. It's using our data to really solve some of these problems so that everybody can go home and do different things. So see you there. And that's it. All right, everybody take care. Stay safe. Hope to see you in Colorado.